Welcome back to Psychiatry Bootcamp. I'm Dr. Mark Mullen. Well, as a podcast host, I would never be able to say that I have saved the best for last, because that would mean I'm picking favorites. But what I will say is that I have thoughtfully placed this episode at the end of season 3. When I set out to do a season on Consultation, Liaison Psychiatry, it was obvious to me that I should do an episode on malingering, and to be honest, detection and management of malingering, and to a lesser extent, factitious disorder, is a bread and butter part of psychiatry residency and a core competency for any psychiatrist. But even though I knew I should do this episode, I didn't particularly want to talk about this topic on the internet. I think it's tough to do this topic justice. Often, when it's covered, it's either in a way that is a dry medical legal monologue, or worse, it's communicated with an us against them mentality, as if we should be so proud to catch people who are being dishonest with us and punish them in some way. And in case it isn't clear to you from the first 33 episodes of this podcast, punishment and an antagonistic therapeutic relationship have no place in the type of psychiatry that I am trying to promote. It really is important to me to discuss this topic in a way that respects and promotes the dignity of every person and that centers our role as healers. I had never really seen this done well for malingering. But then I came across a set of articles from the Consultation liaison folks at Harvard, and I actually felt a wave of peace wash over me, and I knew that I had a duty to cover this topic. In the first sentence, they talk about a Dr. George Murray, who founded the CL Psychiatry Fellowship at Harvard and also was a Jesuit priest. And I am in my 14th consecutive year at a Jesuit institution. It's a mission that I have not talked about overtly on the podcast, but that I hope permeates every episode. And I knew that the approach described in the articles was the approach that I wanted to cover on Psychiatry Bootcamp. I'll link all the articles in the episode notes, and my guest today is the Consultation Liaison Fellowship Director at Harvard and one of the authors on these articles. Welcome to Psychiatry Bootcamp, Dr. Nicholas Kontos, and I will ask you to introduce yourself to our audience.
Okay, my name's Nick Kontos, and I am the Program Director of the Consultation Liaison Psychiatry Fellowship at Massachusetts General Hospital.
Okay, Dr. Kontos, so you're here to talk about the approach to the deceptive patient, factitious disorder, and malingering being the flagship diagnoses associated with this approach. And I have to admit that, especially in a public setting, I am kind of apprehensive about covering this topic. So when I was preparing, I was fighting the feeling that I did not know where to start. And then I came across a paper that you wrote in 2017 about thinking dirty, and my problem was immediately solved. So a fun fact for our listeners, in the opening of this article, you mentioned that George B. Murray was the founder of the Massachusetts General Hospital Psychosomatic Medicine Fellowship, what would now be the CL Fellowship associated with Harvard. And he was a Jesuit priest, which kind of shocked me. And I am in my 13th consecutive year at a Jesuit institution of higher education. And so I felt a particular connection to your article and now a particular respect and reverence for your fellowship program. But back to this thinking dirty, Dr. Kontos, could you tell me what you mean when you say that psychiatry residents and consult psychiatrists need to learn to think dirty?
Sure. I think thinking dirty is something, it's thinking, not ignoring the sort of unsavory aspects of life, usually sex, money, drugs, all these things we're not supposed to think about. And also to consider the possibility, or allow for the possibility that our patients are not being wholly truthful with us. And a lot of that gets sort of hammered out of us in our training for a variety of reasons that maybe we'll get to, maybe we won't. And a lot of what Dr. Murray would teach us was sort of, in a way, a corrective to some of what was ingrained in us. So thinking dirty, he would often push us to look for other motives that might be leading a case to go in directions that people were not expecting.
I think in medical school, especially in other specialties, you have to deal with this less. And so you're kind of trained to this model of simply being a healer and thinking biomedically and algorithmically. And in psychiatry, we interface with the existential a lot more. And, I think we all have parts of ourselves that we're proud of, parts of ourselves that we're not so proud of. And as humans, our motivations for doing things are quite complicated. And so I appreciate just the direct call out of this aspect of humanity that I agree with you often is not very prominent in especially undergraduate medical education. Could you tell us a bit about why patients might decide to deceive their doctor?
Sure. I want to give on that paper a shout out to Scott Beach and John Taylor, who wrote it with me, and to my co-fellows from 25 years ago, Oliver Freudenreich and John Corquist, who wrote a earlier paper where a subsection of it was on thinking dirty. We felt like we had to kind of sanitize some of George's teachings and put them out into the world. So coming back to why people might deceive us, the first step is understanding that everybody does. We all do it. It's sort of it's part of impression management. Because of prevailing ways of talking about this stuff indirectly, we come right out and use the words like dirty and lying and that sort of thing. But any patient who comes to see us doesn't know us, and they want to make sure they're getting due attention for what's wrong with them. So there can be a tendency to exaggerate, or in the language of, say, the MMPI, or modified for this paper, to lie back. Then there's the other side of it where people might want to manage their impression positively. They want us to like them. So, and they often might have been brought in by someone else. So they might lie good. They want to appear stoic. They might not want to be bothered with our concerns, which usually put health and longevity at the top of the list. And that's not everybody's primary values. So they may lie good and minimize. So that's the first step of it. Then once you get past that, you can get to other things that we might consider maladaptive, but still aren't dirty per se. So the patient with SMI who lacks insight or understanding and knows enough to hide their symptoms because they don't want to be hospitalized, or they don't want to be medicated. So that's another way of lying that is not sinister per se. There are other ways of lying dirty, but as for a doctor, the medical ways of it, then you come down to factitious disorder and malingering. And maybe in a minute we can get to kind of the motivations around that and distinguishing one from the other, if they even can be distinguished.
So, in terms of the underlying reason for deception in factitious disorder, what are we classically looking for?
So, for the purpose of people on, listening to you who are going to take the board someday, it's a distinction between primary and secondary gain. Secondary gain being associated with malingering, and that being the gain of things that are tangible: shelter, food, money, disability, drugs, things like that. And you notice in that list, not all of them are necessarily, malingering in some ways is a criminal act, it's sort of medical shoplifting. But it's not always driven by sinister motives. The drive to get off the street if you're homeless when it's 10 degrees below zero, come in and say you have chest pain, I'm suicidal. The problem then becomes, is that really something that the medical system can accommodate? And there's a certain ethics to thinking about that. Then factitious disorder, you get into primary gain. And this can mean a lot of different things. In my own training, primary, and commonly now you ask someone, what is primary gain? Say, well, they want the sick role. Well, what do you mean by that? Well, they want attention. Well, you mean there's lots of ways to get attention, in this case, medical attention. Well, what do you get out of that? So at some point, I stumbled across what the sick role actually is, as a sociological concept. And there are certain gains that you get out of it. It's not enough to be diagnosed with something to get sick role benefits. You also have to, there are duties associated with it. You have to pursue health. But what are the benefits? And that's what falls, that's where the floor kind of gives out underneath factitious disorder. But in the stages that we see them at, what are the benefits? The benefits in this concept are blamelessness for the products of being sick, in your particular sickness, relief from duties, and entitlement to attention. That's where the attention part comes in. And that gets a little nebulous. Does it mean, you know, entitlement to healthcare in the sort of way we might talk about it politically, or does it mean care from, interested others, people in your family, if you have that, or from healthcare providers, if you've gotten to the point in life where that's the last attachment option that you have left. So the sick role, if you think, when you go with blamelessness, relief from duty, and care, what are the opposites of those? Being guilty, overburdened, unworthy of love. Being sick is great one-stop shopping for those things.
So, covering a lot of territory there, the first thing is, when we're trying to decide, especially on a board exam, between malingering and factitious disorder, the real distinction that we're making is what is this person getting from engaging in this deceptive behavior? Is it the primary gain? Is it the quote unquote sick role, having their community rally around them, being able to take certain liberties with the social contract that people who are not sick are not able to take? Or is it a secondary gain, something concrete that we know this person is trying to achieve by deceiving their physician? I mean, I think almost always when we see this in our emergency department, it's achieving shelter, but it could also be achieving changes in a legal status, changes in a forensic case. It can be theoretically achieving food or water, although I would hope that we would mostly just feed and water people if they came to the hospital for that reason. And I think one of the things that I always think about that kind of struck me during residency when seeing these patients is, what do these patients actually have that society values that they can use to get what they need? Well, their life, really. They don't really have much else to bargain with other than, I am a human being and my life matters on a societal level. And so I need to use the only bargaining chip that I have to live a safe life. And I really appreciate in your articles and in your talking right now how you approach this from a very non-antagonistic way, it's almost an impersonal way. It's, as a physician, we have certain ethical obligations, including the stewardship of finite resources. And one of the most difficult parts of psychiatry for me is watching someone languish in an emergency department room for 5 days when what they really need is an inpatient psych bed. And so we do have a duty to protect that. And it's not a me versus you. It's not I can't let this patient pull one over on me. It's not I can't let this patient make me look like I don't know what I'm doing or embarrass me in front of my team. It's simply, this patient has needs that they need to be met, and I have a professional responsibility. And so, how can we work productively to sort of solve this situation and promote more healthy coping strategies on behalf of the patient?
And that last part is really key, because you're you're stewarding resources, but you're also trying. A lot of these patients, we're both talking about how we've seen them many times. They're often not diagnosed, though. If you ask emergency room docs, and people have, this is kind of what passes for evidence in these areas. They're 10 to 20% moderately to definitely suspect this is going on with their patients. Diagnosis rates are usually less than 1%. So there's the stewardship of resources, but we're in seeing them a lot, we're seeing that the strategy doesn't work. So we're trying to also sort of break the cycle for reasons for the patient. It's not working. And for our own reasons, that sometimes, not just with the resources, but sometimes for someone who's sort of a recalcitrant liar, the only positive thing that you might be able to get out of it is that you and your institution won't be a party to it any longer. That might be fine. You could be wrong, or there's not just one way to look at these things. But it is sort of about attempting to either break or not be part of something that is clearly maladaptive and just perpetuating their situation, or in the case particularly of factitious disorder, making it worse over time.
So I think what you're now bridging into is this idea of the therapeutic discharge, two of the articles that we kind of discussed that you wrote. And in this case, you are pursuing discharge sometimes over the patient's protestations, sometimes over the patient's threats and extortions. Could you say a little more for us about how you find such a discharge to actually be therapeutic, to be a way that you can actually treat a patient?
Yeah. So Scott Beach came up with that term for it. And I initially was skeptical of it myself. I'm like, is this just a euphemism for, you know, being a sort of high status bouncer or vigilante? But it's,
You're thinking dirty there, Dr.
I am.
Kontos.
Well, I think you want to say these things out loud so that people kind of know how you're thinking, and also so people can call you out if you're just rationalizing, doing what feels good. Because it does, um, and people should, because all of us who've gotten, at least this far in our education, I'll joke with my fellows and say, even you, are smart enough to rationalize doing whatever the hell you want. And then people will bring up, oh, well, you should do this because it's countertransference and it feels good, but not doing something because not doing something for a reason that it would feel countertransferentially good is just as much you're enacting on countertransference, and that's the same thing. Returning to the question, maybe I'm avoiding the question, how is this therapeutic? So I'm saying why it's not something other than therapeutic. And I've come around on this by thinking more and more about and talking with Scott and others about this. This mainly on the patient side of it, this aspect of, one, it can only be therapeutic for, if we're thinking of patients as factitious, because malingering is not a disorder. There's no therapy necessarily to be had. And that's drawing a line. That's drawing a line between the two that even I don't believe exists. But for the sake of the question right now, I'll draw it.
Appreciate that clarification. Okay,
yeah.
Thank you.
So, but if we talk about people at the extreme, so one extreme is clearly factitious. There is no known therapy, and the only, there's case reports of people, who have been treated, but that's the extent of it. So beyond, what you're trying to do is either have an opportunity to present to the patient the idea that this isn't working. And that goes under the category of confrontation, which carries certain connotations, and you can get advice, do it, don't do it, this, that. And the advice is usually based on the advisor's definition of what it is. The confrontation is partly the therapeutic part. You're presenting the patient with your belief in what is happening. More often than not, they'll deny that, even in the face of lots of evidence to the contrary. But you're not going to litigate it. But at the very least, you're going to present to them, this is high enough. Doctors make diagnoses. We have a list. We don't always presume the thing that we've settled on is right, but this is close enough to the top that at this point, it would be irresponsible of me to not talk to you about this. And this is also when you might be at a point, not of therapeutically discharging the patient, but of implementing an observer on the patient, which they might not like. And say, I can allow for the possibility this might be unfair to you if I'm wrong. But again, it would be irresponsible of me at this point to not do it. Then you can say, weave in the pack, but based on what I do think is right, this is not helping you. You've reviewed the record extensively at this point. One of the few, maybe only good things about electronic medical records and corporatization of medicine is that we have very easy access to a lot of information about patients. My own institution, has kind of stretched out its tendrils to involve a lot of hospitals that now I have access to the records to because it doesn't require consent because it's part of the same system. You could say the same thing is happening to you over and over again, and I don't see things aren't improving. And then it's not just a statement of that, you're also going to inquire about what they think has been missing. It's not sort of saying, why do you keep doing this? What do you think is missing that is keeping you from doing something more effective. Because even if they're not buying into the idea that that they're lying or faking or simulating, they might be able to buy into the idea that they're not making progress in the medical system.
Which in most of these cases is relatively straightforward and obvious. So we are having that therapeutic confrontation to make sure that we are not contributing to the problem ourselves. We are not reinforcing these maladaptive behaviors. We are just kind of laying it out for the patient in plain English, factually, just reminding them that we care about them and we have a duty to them and we have a professional responsibility, and that this is the best thing that we can do to fulfill that professional responsibility at this time. One thing that you alluded to there that you drive home in your article, and I love this part, was this is a really time-intensive process, especially the chart review part of the process. At least one time, right? At least one. Sometimes I say don't be a hero, but in this case, I'll tell my residents you can be a hero, right? Spend the time, review the chart, get a good understanding of this patient's longitudinal history. And then you note that when you're documenting that longitudinal history, you can say, having reviewed 70 encounters over 10 years, the pattern that I have perceived is this, and then laying it out very clearly, very, very descriptively with references to where you're getting each piece of information. And while this may have taken you an hour or more to do this chart review, the next time this person presents, you have saved yourself or the next person a tremendous amount of time. And one of the few rewarding parts about this sort of interaction is when your note does come up again and you have done a good job and you have performed a therapeutic discharge and provided the appropriate documentation with a thorough chart review, you can really save the next person some time and everybody some trouble. So I really appreciated that as well.
It's very gratifying to me now when I see that someone else has done it, when I'm about to do it and I can go through the chat. Oh, okay. I only have to get the interval. But yeah, it's really key. I was talking about good things about electronic medical records. We all know, just for survival through the day, people are cutting and pasting. And the thing that you see very often cut and pasted in the notes of these patients is had a near lethal suicide attempt by hanging or by overdose in X month of X year. And you can go back and, if they were in your hospital at that time, you will see whether that happened. And, for a patient where I've gone to the point of doing that kind of a chart review, more often than not, you'll find out that it's not true. Either it never happened or they presented, but without the toxidrome for the drug in question, or it'll be documented, they say they've presented 3 times that month and they had a hanging attempt, say a week before I saw them, but there were no abrasions or anything on their neck. Things like that. So it's not necessarily nice to be, kind of going in with this stance of doubt. What George Murray would call it would be, being in condition yellow, that you're not going in you don't go in condition red. That would be sort of, then you do think you're a vigilante or something like that. But condition white is just, I'm going to just take everything that comes to me at face value, which we probably shouldn't do with patients in general, or ourselves for that matter.
100%. And you also make a really strong point that, this is not the first time our institution has seen this patient, that we are having this conversation, that we are taking this approach.
Right. Never the first. Yeah. The first time you might have your suspicions. And I've had occasions where a resident will have a strong suspicion or a fellow or whatnot and bring me in and they expect, sort of fireworks. You were saying it seems neutral. It's not always neutral in these situations. You strive for that. But, and, we come out of the room and say, we know, and, that's with quotation fingers, that we're being duped. But if this is the first time the patient presented, we human beings are not good at detecting lies in other unfamiliar human beings. And we have to acknowledge that. And so when we are going to the point of doing it, it's because we have a lot of information. It's sort of the institutional familiarity with the patient is subbing in for your personal familiarity with them.
Building a relationship with the institution over time and these sorts of longitudinal emergency department relationships as opposed to a one-on-one longitudinal relationship. And I would argue that it's not the person who allows themselves to be, quote unquote, duped or who gives the patient the benefit of what is really actually a very strong doubt on the first or second presentation that is kidding themselves. I think the doctor that's kidding themselves is the doctor that thinks, A, they can reliably detect this, and B, that if it's not happening to them. Like I feel like a natural part of our job just has to be we're not always going to get the 100% truth. We are always going to do our best to serve our patient, and we need to be able to go to sleep at the end of the night.
Yeah, you really have to kind of divorce your ego from these things, and that can be the part of the ego. Well, I don't mean ego in a Freudian sense, but the lay sense, the part of the ego that wants to be maybe had some kind of medical police action and gotten this bad actor out of the hospital, or the part of the ego that wants to be the hero in the movie of this patient's life. I'm going to, and has rescue fantasies that really, frankly, we often see attempts to enact, but really the medical system is not equipped to fill in for the places where society is neglecting, its citizens, or where people have just sort of, we can argue, no one does these things for fun, but there's, points where you're doing it because you have to, and then there's points where you're doing it because, I don't want to say choose to, but something closer to that end of the spectrum where maybe it can be modified.
And sometimes for good reasons, wanting to excel, wanting to get a good letter of recommendation from your program director, wanting to be the best, because doing well on standardized tests is maybe what got you to this point, but there does need to be a flip when it comes to patient care that says, my goal in patient care is not to be the most successful or win the most awards. My goal with patient care is to wash this patient's feet, to be the most, to serve this patient, to do what I can to help this patient better their lives. And a lot of times that requires a whole different set of motivations on our part than just being the best. Psychiatry Bootcamp is brought to you by Simple Practice. Simple Practice saves you time so you can focus on spending that time with the patient and not on writing notes. Simple Practice now has an AI-powered note writing tool integrated within the health record so that it's a true all-in-one EHR. Simple Practice is HIPAA compliant, it's high-trust compliant, and you'll also love the PDMP checks integrated within the portal and the easy-to-use lab order templates. Simple Practice saves you time so you can focus on what matters most. For a 30-day free trial of AI Note Taker and a PBC exclusive 7-day free trial and 50% off 4 months for Simple Practice EHR, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Psychiatry Bootcamp is brought to you by Beat the Boards. Listen, Beat the Boards is offering us a ridiculous deal. Bootcamp listeners now get free access to over 4,400 USMLE Step 2 questions and over 4,500 questions for Step 3. This is not a discount. It's completely free. Don't miss this opportunity. Go to beattheboards.com/bootcamp to get started today. I used Beat the Boards to study for my own board exams, and I found them to really reflect the real exam and make the exam a breeze. Give it a try. Beattheboards.com/bootcamp. Okay, I want to dive into some clinical pearls here for our listeners. When we're thinking a patient might be deceiving us, what are some interview strategies that residents might consider using to get a more veracious history from a patient where deception is a concern?
So there are some concrete ones that we've talked about, in the paper. Scott likes to use the Columbo method, which he and I are old enough to remember Peter Falk's Columbo, who was sort of a schlubby TV detective whose superpower was that people would underestimate him. And he was sort of the ultimate doorknob comment, kind of leaving. And, oh, by the way, you've reviewed the chart and you've seen that the patients come in, 5 times because their mother died in 5 consecutive years. And I noticed you came in, your mother died these 5 times. Do you have 5 mothers? And that's a little, that could be a little, you know, it's skirts wise. Well, it doesn't skirt, it is wise-assery. And you don't quite want to go there at the beginning. But it's an example of sort of asking an obvious question that's there, in the air. So playing dumb, and other ways are one thing that the things I do, the things I personally do stem from what I would do with any patient. I don't know if this gets taught anymore, but when I was taught psychiatric interviewing, one of the things that was used was Sean Shea's book on the art of the psychiatric interview. And this is no longer necessarily possible time-wise, but the advice at the beginning was just let the patient talk for 7 minutes if they will talk for that long. I don't know why he chose 7.
Probably so we'd remember it.
Yeah, I think so. Yeah, I did. But I think of that as something that can be prorated. So I'll let the patient talk for 3 minutes, which can seem like an eternity to some people, frankly. But you will, at the very least, get most of your non-cognitive, well, some of your cognitive too, mental status exam. You'll get a lot of the rest of the mental status exam, and you'll find out what's most important to the patient. And given time, it might go beyond I'm suicidal. And if it doesn't, then that's sort of a clue right there. That's because they're coming for help, and then you're going to say, okay, I got to leap in with questions. So you're going to want to see if the patient is going to participate in getting the help that they claim to want. We've all had the patient where I'm suicidal. Well, tell me about that. Well, don't you know what suicidal means? Yes. There are a lot of reasons people can be suicidal, and on from there. And then I want to take the patient to places that could potentially reveal a future orientation. And, so far I've let them talk spontaneously. And the number one question the things that I'll ask to get to future orientation or to other aspects of what's going on so that we get past the immediate concern are, when were you last your normal self for, say, a whole month? Describe that to me. Because I want to know that. And that, like I said, this is for every patient. I want to know what their, maybe not healthy self, but less baseline self is, as much as I want to know what their sicker self is like. Then the high yield thing after that, what do you do all day? What have you been doing all day? And that can take you off on topics that are going to lead you to other aspects of the patient's life. And this is either going to give you valuable clinical information for any patient, or it's going to get you into an area where you're going to start getting attuned to inconsistencies in the patient that's coming to you with the goal of deceiving you.
Let me summarize here, and then we'll go into those other couple. So one thing that I really appreciate here is that you are holding space for the fact that different psychiatrists are going to take different approaches to this. You and Dr. Beach have your own kind of preferred methods, it sounds like. I think everybody has their own favorite questions. And I really appreciate that. One of the most fun parts of being an attending these past 9 months have been seeing all of the different residents' personalities and all of the different interviewing styles. And I can tell you off the top of my head which residents absolutely killed this. They're so good at going into a patient. And what you're really talking about is chatting, just kind of chatting about life and listening intently and allowing the person to feel comfortable and tell their story a little bit. And as you are just chatting, you're actually picking up on some really important information like future orientation or potential inconsistencies with the medical record. Same with the how do you spend your days question. Is the way you spend your days consistent with the way the record says that you spend your days, the way you are presenting when we actually do start to talk about kind of the reason that you're here, et cetera. So appreciate that you're giving us latitude there, and that a big part of this is just building that therapeutic alliance and kind of chatting about things that don't necessarily seem relevant, so that you're setting yourself up to have kind of a more in-depth conversation later. So that would kind of be one that's a little bit like the Columbo method. Any other specific interviewing strategies that you think are important?
Yeah. So other things, and usually, these things I do sort of lead into some of these other things that Scott has worked with. So he talks about gentle assumptions. Instead of do you cut? When's the last time you cut, or when's the last time you did this thing that might be, I keep saying unsavory, that kind something unsavory, and that will either produce information that maybe the patient didn't want to give you to start with because it's their impression managing, or for the patients that we're talking about, it gives space to maybe produce things like some improbable hyperbole. 5 minutes ago, oh, can you show it to me? Or yesterday, oh, can you show me the laceration from then? And what did it feel like? That kind we do this all the time with people who drink. You'll say, instead of, um, how many drinks do you have a day? What's your drink? And okay, and they'll, sort of, if it's beer, how long does it take you to go through a case? Don't ask how many beers in a day. Take a large number, and they might say one day at that point, rather than underestimate it. Or people will say, I have, if they're semi-fancy, I have one glass of wine a night. And usually my comment to that, well, the bottle's made of glass. How big is your glass?
That's a great response. That's a great response.
So,
Because my guard is totally taken down. I'm like, this guy gets it. That's great.
so all these little things, and they have to be, they're also, it's hard to always to describe all the things you might do, because there are also things that you acquire through the process of seeing tons of patients and getting to know yourself. Because if it's not something that's authentic to you, it's not going to produce good results. It's like using humor with patients. You have to use it in a way that is authentic to you. Like I'm prone to swear. I'll preserve the whatever rating your podcast has here. But if someone does that and that's just not part of their vocabulary, it's not going to come across right. So you have to do things that are part of your authentic self, which is sort of part of the irony of these interviews. Is there are things we're withholding from the patient. Like maybe you might block them from being able to see that note, or you're not telling them you're going to therapeutically discharge them before it's actually going to happen. But in the actual interaction with them, you're trying to be as authentic as possible.
I think, again, in order to do that, it requires, if we're using the layperson terms, setting aside our ego, reminding ourselves that we're here to serve, and that we're, fulfilling our professional obligations and still caring about the patient in this way. What about this asking about low frequency or impossible symptoms? Could you give us an example of how that might work?
Sure. So this is something that I think forensic psychiatrists are very used to doing. And it's useful for things like, it's useful in somatization. It's useful in psychotic disorders, some somatics, in a somatic review of systems, do your teeth ever itch? I've been told once that that's possible. I've never seen someone who spontaneously complained of that, though. But you'll see plenty of people who will say yes if you ask them. Then, as far as hallucinations, do you hallucinate in black and white? The patient has to be old enough to know what black and white things looked like. Or you could say, do you ever hallucinate in low-res graphics? You could, for delusions, do you ever... Scott came up with this one. Do you ever believe all of the cars are plotting to take it over humanity? That's or I'm a big bird person, that the birds are all plotting to take over or that they've all been
Well,
replaced.
that
And
one
so,
is actually true, but we don't need to discuss that on
yeah,
Psychiatry
that's
Bootcamp.
the whole,
Yeah, I'm not willing to have that conversation with you, Dr.
the whole
Kontos.
the performance art of that. Yes.
Yeah. My partner's favorite is, do the voices get louder when you defecate? I think
Oh,
there's a
that's a
lot of
good
these
one.
different creative ones that
Hmm.
you can come up with.
Yep.
So, asking about things that seem quite unlikely or that would not match the constellation of symptoms that the patient is purporting to be experiencing.
Hmm. Right. And this also, you can do it it can be improbable also with what they've already told you. So if they've told you they spend their days, oh, I'll watch last night up here, I watched the Red Sox and, oh, how did they do? And then they get it right. They were engaged, they won. Then later, so what do you enjoy doing? Nothing. I don't enjoy anything. And you don't have to put to the patient, well, how do you match that against this? Because then you're starting to litigate. You're just taking note of these things and seeing if they pile up. Everybody's allowed an inconsistency or two. But when the same pattern is happening in the same person over and over, that should get your radar attuned.
So these are some techniques that you might use kind of throughout the interview with the patient. And another point you make is maybe over the course of not just in the initial psychiatric intake, but sometimes you are setting yourself up to use these strategies over the course of a few days that the patient might be in the care of your system. Other than these sort of techniques, are there any standardized instruments that trainees can consider reaching for when we are considering a diagnosis of factitious disorder or malingering?
Not that I know of. In neuropsychology, um, there are, on the MMPI and the PAI, there's a lie factor. Um, but even that's imperfect. It's almost sort of I'm not a forensic psychiatrist, but reading about at least malingering in this area, because you wouldn't really have factitious disorder necessarily there. But you, it's almost a holy grail of neuropsych testing to find the thing that's going to tell you if someone's lying. The most you can do maybe is measure effort, but that's a different matter. So the short answer was no.
And this is a really, and this is why we're covering it in Psychiatry Bootcamp. This is really kind of a foundational part of being a psychiatrist working in these high acuity settings. And we really probably shouldn't need to order full neuropsychological testing to diagnose. And it's really based as much on the context as the presentation, and some of that's not captured in the neuropsychological testing. So, unfortunately for our listeners, there is no standardized instrument that's going to make this much easier. You're going to need to rely on your clinical judgment and a good, strong history, collateral history, chart review, etc. Let's talk a little bit about documentation in these cases where we feel like we've been able to gather a pretty strong history from the patient. We feel like in our clinical judgment, let's say malingering is the most likely diagnosis, and we're thinking about moving toward a therapeutic discharge, despite the fact that the patient is making some pretty concrete statements, threats, we could call them, maybe holding us emotionally hostage, that the patient's going to do something, etc. What are some documentation pearls that you think listeners need to be thinking about when setting ourselves up for a therapeutic discharge?
Sure. I think there are some to put that go in each uh, part of your write up, and this was we if people want to look at some of that, we put out a second paper on therapeutic discharge that has examples in it. So your note is going to be a recognizable medical note, but there are going to be some differences in it. So in the HPI, I think of it as being in phases. Even if the information didn't come at you in this particular order, you know, phase one of the HPI might be the things that the patient spontaneously told me. Phase two might be where I'm looking for consistencies and inconsistencies. So this is based on things now that I elicited that I'm comparing to what was provided spontaneously. And then the third part is might and you could argue whether this is really HPI, but I think this is really the only place it belongs, is what their goals of care are, and a little bit about their how they participated in pursuing those. Whether the patient came in, I'm here to get treatment for my depression. I'm terribly, horribly depressed and suicidal. Okay, and then whether you went, say, the Psyche CAPS route or you went the conversational route, how did the patient respond? And it might have been that they responded with across the board hyperbole about every symptom, or it may be that they refused to engage with that, which would not be consistent with the desperate need for help. For the past medical history, we've already sort of talked about that and the way that you might. The one different thing is that, we usually don't brag about how much of a chart review we did in there, but in this note you would, because you want to lend you need credibility in your documentation. So that and the noting of inconsistencies in a neutral way. This is a neutral part of the note. You'll want to put those down. Just the mere fact that it is inconsistent. The mental status exam, you want to draw a comparison, if there is one to be made, or a contrast between the patient's spontaneous performance and the elicited performance. This kind of goes on consult liaison psychiatry. This goes for every patient, because you got to go into every patient interaction, assuming that someone is not going to participate in the sort of standardized, they're not going to do a MOCA. That's not their priority. That's not what they came in for. But if you've worked in through conversation, how long have you been here anyway? And but the patient might not know that you should know that. And ask about elements of their stay, brought them in. So that now you've got things about their recent recall. Then if you do standardized testing and it's just 0 out of 3, 0 out of 3 with cues, 0 out of 3 with prompts, 0 out of 3 with multiple choice, there's a discrepancy there. And that doesn't always mean the patient's lying. It might just mean they're not motivated to do your testing, but it could also speak to they're being disingenuous. So you'll note the discrepancies. And it's not just cognitive. There may be a discrepancy between their affect as the exam goes along versus their stated mood and the stated pervasiveness of their despair. Not to say that patients don't feel bad, but this isn't sort of how most of us would choose to spend a Friday night in the emergency room. But it's not matching up with what they are reporting that they came in with.
Incongruent affect.
Incongruent, yep. Then you get to the assessment and plan, and if it's the first time you saw the patient, then you're not going to put a diagnosis. You mentioned this before. You're not going to put the diagnosis or the formulation there. You might put in something embedded in the narrative, because we all know people don't really read anything but the bottom line of the notes. But you want something there that might help someone going in the future about, I do question the consistency of some of the patients' comments about X or Y. And, and some of this is because you don't want to come to premature closure. Some of it is because if you are admitting them, you don't want to sabotage your prior authorization by labeling someone as, having high probability of lying. And then beyond that, it's like any other assessment and plan. You're explaining why you came to this conclusion and doing it with rigor that kind of wraps it all up. And a lot of that, the hardest part isn't necessarily sort of the narrative assessment. That might be the most time consuming. The hardest part in a way is like putting down malingering, say, that, as the it's a Z code. I'll say diagnosis, is shorthand. And just say, boom, that's what's going on here. Factitious disorder equally, it's sticking your neck out. But that can be the hardest part of the assessment.
Well, and you've been very clear that you're not rushing to a conclusion. This is not the first or second time the institution's seen this patient. We have an extensive chart review to support it. You've done a really thorough interview. You've picked up on inconsistencies. You've picked up on the incongruent affect. You've picked up on how this patient has interfaced with treatment in the past and now has a very strong record of how they intend to interface with treatment in the future. And so you are sticking your neck out ultimately. And I appreciate the reverence with which you are approaching making, actually documenting the word malingering. And I think that it deserves that reverence. I also think there is a time where to not do it is simply to forsake your responsibility because there really is enough information there to do it. And it's time to go ahead and make it official.
Absolutely.
One of the things that you mentioned in this article, and we're going to link all three of these articles in the show notes, just so you know, but I'm going to read this quote to you, and I just would like if you could expand upon it a little bit. I want to make sure I understand what you're saying. In busy hospital settings, patients are often gone before notes are written. We do not feel that typing notes while talking to the patient is very appropriate during a therapeutic discharge situation. Yet, post-discharge is not a good time for second thoughts about one's clinical decision-making that may arise during or upon completion of documentation. I really appreciate those few sentences, especially as someone who thinks about workflow for learners. What are you saying there? Are you saying there's a specific time in this process that you feel like the full H&P should be written?
Yeah, that's me trying to thread the needle of the fact that reading that paper on documentation, it's a lot to ask. And it's a lot to add that this isn't the only patient you're seeing. So the likelihood that you're going to write the note that this assessment and potentially discharging someone who is actively saying, I'm going to leave here and stab myself in front of the hospital. But on the other hand, it's easy to get lost in the idea that these notes are just to provide medical legal cover for yourself. When, there is a place for that. You're doing something, that sort of objectively is risky, or maybe more subjectively, if you've come to the conclusion that we're talking about. But the real purpose of the note, in my mind, is to make sure it's keeping yourself honest. Sometimes, it's the speed of thought versus the speed of typing, is rapid. And you want to make sure that you're not being overly guided by intuition. Not that there's no place for intuition. We underestimate that, but it can't be purely that. Nor, people will say, nor that you're being purely guided by countertransference, which I think the word gets overused with these patients because you're just having ordinary feelings towards them. I don't think we need to give it the window dressing of, nothing against the concept, but I don't know if it's applied correctly here. So what I'm saying in that part is trying to at least compose a version of the note in your head and see if it fits together. Bounce it off a colleague. If you're a trainee, I would say this shouldn't happen without an attending being involved. This week I'm the backup on-call person. So if someone called me overnight saying, this person's in the emergency room, I want to therapeutically discharge them, it's unlikely that I'm going to say go for it. I think that some trainees are precocious and they're going to be very good at this. But on the other hand, it's unlikely. It should. I'm not going to be able to compose that note in my head, even with the best on the phone presentation. So it's about sort of, if you can write the note in advance, good. There have been times where I've written the note for a factitious disorder patient while they are still recovering from something they did to themselves, and realized that in the process of writing it, I had thought at the beginning, therapeutic discharge, but by the end of the note, I've changed my mind because it's clarified my thinking. Otherwise, I'm probably overemphasizing not doing these things, but mainly the purpose of the line you're quoting is to make it credible why you are doing it, including to yourself.
No, that makes sense, and I think the reason it struck out to me, the reason that it stuck out to me is I can think of, and not just factitious disorder and malingering, but a lot of these more difficult decisions that we make as psychiatrists that are a little bit more complicated, that are a mix of intuition. It's not a straightforward, are you suicidal? Yes, I'm suicidal. Great. Voluntary admission to the unit. We're going to start an SSRI, right? This is a whole kind of different can of worms here. And just personally, especially going through training, but even now, it really, for me, sometimes is not until I have sat down and put all the information on paper and looked at it in an organized way that I start to have maybe some second thoughts, or more often actually feel more comfortable because I say, okay, now that I've actually seen all this on paper, I do feel like this is, to a reasonable degree of medical certainty, this is my professional medical opinion. And so I just appreciated the call out of the documentation being important for our clinical decision making process. I don't know that it's always thought of that way. And you're also, unfortunately for all of our listeners, I think, who came to listen to this episode, hoping that they would learn how to spot a faker and be a better cop, you're reminding us that we probably shouldn't rush this, that even if you have a pretty strong intuition, this is such a serious decision that it might be worth taking a beat, at least discussing with your attending before making a major decision like this, et cetera. So just appreciate you giving the topic the reverence that it deserves yet again. You brought up the feelings. I like that you threw shade toward the countertransference. I agree. I teach about countertransference often with these patients, and I think it's important to recognize their countertransference for a number of reasons. But I also think that if anyone were to use intellectualization as a defense mechanism, it's probably doctors. And sometimes by using that language, we are allowing ourselves to give that defense mechanism a little bit more power over ourselves than it probably deserves. Because sometimes we're just upset, and sometimes we feel used, and sometimes we're burned out and we're tired, and we feel like we're putting our hearts on the line to help people, and they're taking advantage of us. And it does feel personal, even when it shouldn't. You make a big point in your article about the things that you guys are doing at Harvard to support your residents with these difficult topics in psychiatry. What do you think is the hardest part of dealing with patient deception for a trainee, and what advice would you give them?
I think the hardest part is the burnout that they produce. If it's true, well, we know it's true that it's suspected frequently. Uh, so if 1 in 10 or 1 in 5 patients that you're seeing evoke that kind of concern, that's going to get burdensome after a while, especially since we've, in your previous stop through medical school, we were taught that the doctor-patient relationship is this sacrosanct thing that is, George would have said all sunsuits and lollipops, and, a little love fest of great respect in both directions. And anyway, I could get more hyperbolic about it.
Kumbaya.
Yeah, exactly. And then you meet the patients, and a lot of them are not like that. And I think that if you are not only seeing that often enough, there's hostility that from patients that can be, and deception that has legitimate. I talked about sick role blamelessness. If someone with dementia is, giving you a hard time, or someone with mania is being grossly inappropriate, we cut them some slack. If someone with, say, personality disorder, or we eliminated the axes in DSM because all of these things are equal, but we don't think of them equally, and it comes down to this thing of how blameless are people. So I think, for in the subgroup of that of deception, it can be demoralizing when it's a situation where you frequently are suspecting or know that you're sort of the next step of work that I'm kind of focusing on with this is being in a unilateral ethical situation, which can be a little self-flattering. I'm the only person acting ethically here. But it can feel like that. And that when that is repeated, it can produce burnout, I think, because it can make the work feel diminished, unfulfilling, especially if you're not working with people who are going to allow room for the possibility of saying out loud what they think is going on. And, at least that, and maybe of acting upon it. And sort of, saying, we're not going to admit this patient. We are going to take the superficial risk that something is going to happen. So I think that is the biggest effect that I see on trainees. The other effect that can happen is that you don't get burnt out, you just get apathetic. It becomes sort of a situation where someone comes into the emergency room, they say they're suicidal. It's sort of, you take a ticket off at the deli counter and you wait your turn to get admitted. This is a way of, instead of that, you can, despite these seeming like they're not part of the doctor's job, it can instead feel like this is an exercise of my training. Because it's as important, what do we say all the time in medicine? Rule out. You're ruling out the possibility of what they manifestly came in with and ruling in something different. And it might be that you're ruling out pathology completely. Well, maybe in a minute, I do want to take a moment to talk about that blur between factitious and malingering and what is the disorder status of either of these things.
Do it. Let's do it. Go ahead.
Sure. If you think about those two things, and we lump them in with what used to be called the somatoform disorders, now the somatic symptom and related disorders. We made it a mouthful, but at least we lumped some things for once. And if you look at those functional neurological disorder, factitious, malingering, they vary only on it. It can get complicated, but they only vary on three parameters. They vary on whether you're presenting with symptoms or signs. They vary on whether you are doing it intentionally or unintentionally, and they vary on what type of gratification you're getting. And these things are not binary. They kind of, there's black, white, and gray for each of these. If I stick purely to factitious and malingering, the party line would be symptoms or signs. Malingering will be symptoms that are telling you what's going on. Factitious will be signs that have done something to themselves. That, however, that where the gray comes in there is that it's really a artifact of the stage at which you're finding them or the thing that they've chosen to do to themselves. So both of those are just two different shades of gray. One's a little bit tilted towards sign, one a little bit towards symptom. So no big difference there. If you go to whether it's produced intentionally or unintentionally, you can't do either of these things unintentionally. You think of a factitious disorder, the classic factitious disordered patient. It would be hard to inject your own stool into your intravenous, unintentionally. If you come to the gratification and come back to primary and secondary gain. If primary gain is the sick role, it's what's the line between relief from duties and a disability form? What's the line between care and getting hospitalized? There's really the distinction between primary and secondary gain is received wisdom, and at the extremes, yes, you can tell the difference between them. And I'm dwelling on that category because it comes down to that being the only thing that distinguishes factitious disorder and malingering. So if, other than at the extremes, they're not they're impossible to tease apart. That either means that we are being overly generous in calling factitious disorder a disorder, because it's no different than malingering, or that we're being uncharitable to malingerers. So then you're left with, well, should I think of them all as sick? Which some people would say, because you can trace back the reasons why people are doing things, or you can treat them all as medical shoplifters. They criminalize both groups. My thought is that I can't imagine that anyone, pinned down would say that factitious disorder is a disorder that we're going to research in the ways that we research bipolar disorder, depression, schizophrenia. Not that those are really natural kinds, but it's the best we can do. But there is a distinction between the two. So I think it's less important to really distinguish the gray zone cases of factitious disorder and malingering, and more to make an attempt to get at think of them as behaviors and get at the attempt. And when you think of people talk about treating factitious disorder, odds are if you're going to successfully treat it, what you end up treating is the use of illness as an attachment style. And I'm saying that, I'm just declaring that, that could be debated. But I think very few of us who have met a few of these patients have seen factitious disordered patients where we didn't think that there was a personality disorder also going on.
I haven't seen one. No, for sure.
And it's interesting because there was a review of 455 reported cases that found only a 16% rate of personality disorder. But one, these are reported cases. Two, they had to get the diagnosis. And, three, if you're making a rigorous diagnosis of personality disorder, these patients aren't sticking around long enough. And finally, it's you're relying on self-report to make some of these diagnoses. So I think managing it as an attachment style or as an attempt to meet other needs in your life, that's the way to go. And that opens up the avenue to have conversations with these patients. And, it's easy to sound naive when I say that, but I think that what I'm talking about there is the obligation of the doctor to attempt that. But you have to go in with the expectation, though, that the patient's not going to participate. They're going to try, one of the counter arguments we get sometimes to the therapeutic discharge thing is, well, the patient's just going to go somewhere else. But I don't see that as a compelling argument to do the wrong thing.
Right. Exactly. Unless I'm misunderstanding something, none of that sounds naive to me at all. It sounds quite seasoned. And at first I was thinking, wow, this got really heady and really philosophical really quickly. And then it got really pragmatic just like that. So you're saying that you see factitious disorder and malingering on, maybe fair to say, a spectrum of deceptive disorders where the middle of that spectrum is not so clear. Which sounds confusing. And then you bring it back to, but what is the behavior? What ultimately is the final common pathway for whatever this, call it a disorder or a disease process is, this constellation of signs and symptoms is, and how can we most effectively deal with that to serve the patient and to effectively fulfill our role, our ethical obligations as psychiatrists and as healers. And whether we call it factitious disorder or malingering, the ultimate result is that I don't have any medical interventions that are going to be helpful for you here in this hospital. And the most helpful thing that I can do is encourage you to take responsibility for your own life and give you the freedom and latitude and life experiences to learn how to solve some of these problems with, as you make a clear point of, access to outpatient care, access to the appropriate psychosocial resources, but not reinforcing those maladaptive behaviors in the hospital, I think is kind of the final common pathway in terms of treatment. So that was a really brilliant take. Do you feel like I understood that mostly correctly?
Yeah, I think you do. Yeah, I think the spectrum idea is right. The way I would view it is sort of malingering and factitious. We're talking about infrared and ultraviolet, and the visible spectrum is everybody else.
Yeah.
So yeah, I think that fits quite well.
Great. And then the other thing that you mentioned too, when just kind of getting back to what the hardest part of dealing with this is for a resident and the advice, one thing that I kind of picked up on there, when I was a resident, I told myself that when I became an attending, I would give a speech the first day of every new set of people that came in about the learning environment and how the learning environment is the alpha and the omega, and you need to feel safe to ask questions and make mistakes and say what you really think and be honest about where you're at in your educational and developmental process. And I am sad to report that I have failed at that obligation. I hope I promote a positive learning environment, but I do not walk into work every day and remind people that it is the alpha and the omega. But thank you for bringing us back to that there. Our role, especially as supervisors, but trainees contribute to this as well, is to promote an environment where people really can say what they think, where people are not scolded for being honest, where people are supported. And so I appreciate you centering us around that.
Yeah, and where you can challenge each other in a way that is productive, and not, whether people get defensive or not, that's up to them. You can't really control that. But yeah, and I don't think I wouldn't beat yourself up about not giving the speech, because what's more important is what you're doing. As I think there was one other thing I want to shoehorn this in a little bit is, in terms of how patients are treated, because what the final step of the therapeutic discharge is that they're escorted out of the hospital by security. And this isn't sort of a walk of shame or something like that. It's because you want to reduce the chances of mischief within the hospital. We used to ideally, we want them escorted off hospital grounds. And we tell them in advance this is going to happen. And it can seem punitive. And something that you had said earlier reminded me that, I said that kind of discovering the actual signal was a eureka experience. A more recent eureka experience for me was kind of learning a little bit about don't worry, I'm not going to get too heady about this, but the moral philosophy of blame. And you can get into free will and all that stuff, but we won't get, for the sake of this, there's a thing about, called the reactive attitudes, which have to do with our interpersonal stances toward each other, which is based on what I think your quality of will toward me is, and that then I can respond to that. And those aren't always, it's the article that comes from is called Freedom and Resentment by P.F. Strawson. And then there is a huge, literature, and I'm not a philosopher, that I'm not trained to, I've read a lot of it, but I can't claim I fully understand it. But one important thing about the reactive attitudes is that it is, even when negative, it's considered to be a way of affirming that the other person is your moral equal. That doesn't mean you think that they are behaving morally in that moment, but that you have the expectations of them that you have of another member of the moral community. If you go all the way past that, for us, we'll say you're taking the objective attitude toward them, that it would be unfair to blame this person. He specifically talks about severe psychological dysfunction as a reason for that. But at that point, they'll talk about them that they sort of cease to be a member of the moral community, treating them as an object or something to be controlled or studied, rather than as a fellow equal. So, this can be mobilized as a rationalization for acting on the negative feelings you're having towards someone. But also, there are, we've all faced negative consequences for our actions. And in some ways, doing this is also an affirmation of the fact that you're viewing them as a equal. And we jeopardize that sometimes in psychiatry if we overplay our card about how compromised we think some patients are. But that's a whole other difficult judgment to make. But in consultation liaison, people are often asking us to make that judgment. How responsible their actions are in this patient, or if you're trying to explain to a distraught consultee why security is coming to the floor or why they should agree, because it's their patient, why they should agree to have security come to the floor and escort their patient away. So there's a lot of layers.
There are a lot of layers to that. I think You could view it through the lens of operant conditioning and reinforcement, or you could view it through this more humanistic lens of moral equals. It reminds me of a case that I saw in residency, a patient who was drinking and driving and ended someone else's life in a car accident. And it somehow, just because these difficult conversations often do fall upon the consultation liaison team to have these conversations, we kind of had to have the conversation. And one of my medical students asked me afterward, like, how do you have empathy for a person like that? How do you, like, this person wasn't taking any responsibility. How do you deal with that? And I was kind of shocked by it because I had left the room thinking, how lucky am I to be able to have this interaction and be there for this person who made a big mistake at the lowest moment of their life, because this person is my moral equal. And of course, I've made big mistakes too. Luckily, none that have resulted in that. But gosh, there are things that I would not say on the internet to a podcast audience. And I think that what you're getting at is seeing ourselves as sort of one in a way with our patients, not better than them, not worse than them, but coming from a place of mutual care and mutual respect. And that means holding people responsible for their actions and helping people to change their patterns of behavior rather than simply allowing or even encouraging and worsening a maladaptive pattern of behavior to continue.
Mhm. Yeah. And coming in contact with these kind of things is also what gives us, there's a selfish element too. It gives us more expertise. That's one of the things that also our patients, maybe not consciously, but that they count on us for, that we've been there before. We've been proximate to the extremes of life that most people might encounter only a handful of times in their life if they're lucky. Your patient also, it's sort of the empathy could also be, it's hard if the patient has no regrets. And, in that case, I might shift to sort of that selfish mode. I'm curious, how is it that you don't have any regrets about it? And then maybe I'll learn something. I can't, or you learn that that's just their defense. And, then you got to decide, do I break through this now or not? While they're on the mend. Then you get your other folks, and I'm going afield. You can interrupt me if you want. But the relapsed substance user who's in total shame mode, and be honest with them to say, well, it would be abnormal. Would bring, if you were proud of this, would probably bring more psychiatrists, because we'd have to kind of study this reaction of yours. What I'm interested in is moving you and maybe this is the same stance I would take if I ever did get one of these malingering or factitious patients who broke down in shame over their behaviors with me in a genuine way. Say, I'm not looking for shame. I'm looking, what I think would help you would be regret. Regret you can work. Shame, I do think there is a place for shame in life, but in these interactions, no. That's not going to be productive for you right now. And I don't feel like you should feel ashamed for anything that's going on with you and I. But, I would hope that you would regret it. And then we can work on why you regret it and how to make it not happen.
And learning from it. Wonderful. Well, the quality of my will toward you is 100% gratitude for you making the time for us this morning, sharing your expertise. Dr. Kontos, do you have any final thoughts for our audience?
No, I appreciate having an opportunity to speak about this, and hope that people will think about it, not just agree with everything, but kind of use it as ways to consider their options. And I really appreciate you inviting me. This has been a fun conversation.
Thank you. Well, you've put out a lot of literature beyond this podcast, so we'll link some of that in the episode notes. And for interested listeners, they can familiarize themselves with your body of work. And I look forward to continuing to do that and hopefully seeing you around. And thank you so much.
Thank you very much.
Thanks for listening to this episode of Psychiatry Bootcamp. If you enjoyed the podcast, please take a minute to leave a review on Apple Podcasts or a rating on Apple or Spotify. You can reach me at psychiatrybootcamppodcast@gmail.com. Find me on TikTok or Instagram at Psych Bootcamp. Our theme music is by Cave Radio. Special thanks to Matthew Braddock for production support. The opinions shared on this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete, accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice. This is a Human Content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.